Dwayne, as a cath lab director, we'd love your thoughts on imaging, consistency, trying to kind of keep people within norms in terms of, a little bit less heterogeneity to practice, and how you see this as potentially improving quality and making your job easier, and how you would advocate it from your position as a physician that leads multiple interventionalists.
Yeah, so, I was with interest listening to your evolution, Kevin, because I was much the same. We trained around the same time where, bigger is better. I post-dilate to 20. I'm, very testosteronized, and I know how to do this. And me having the same realization as you of that I wasn't really doing as good of a job as I thought I was. That was the first step. And then kind of as the cath lab director, variation is on one side is relatively difficult to deal with, especially if people haven't bought in intellectually. So there are people who systematically undersize, and that's a tricky one to deal with. But you can't argue with the pictures when you really see it, because the angiogram is misleading. And that's what, I think the lesson number one of when I thought I had a good result so many times, and you showed the data, even though I thought I had a good result, we had to change. So I think that accepting humbly my own deficiencies and setting an example to avoid variation was important. So kind of a rising tide led by the younger folks, really has helped our laboratory. And just to put some numbers on it, going all the way back to 2004 to 2016, we never did more than 50 imaging cases. In our denominator of, varies over those years, but it was never less than 1,000, 1,100 cases. So that is ridiculous, right? And with comfort in imaging, dispelling the rumors of more contrast, more radiation, more runs, seeing things that you don't know what to deal with. We did 471 cases imaging cases last fiscal year. So, I think that, whatever the proportions are, the percentages are, just like every tool that we have in interventional cardiology, you have to use it as a tool and know how to use it instead of saying it's not a tool that we need. And then one final point is people talk about cost. There's a lot of cost related to your time, your radiation exposure, the patients on the table, the complications that result from that. There's costs associated with restenosis events and these sorts of things. You're going to get into the clinical results. But, I want to dispel people, even as a cath lab director, that acquisition cost tells the whole story. So it really has, for me, very little to do with what the cost of a catheter is. You're worth it.
Yeah, and I think, unfortunately, we're not looking at the long-term 1, 2, 3-year TVFs that occur by not using imaging. The data would suggest that those are cut down by half, and currently 12.5% of all of our PCIs are done for stent failure. And your partner, Bobby Ye, had a beautiful paper last year that shows that stent failure kills people more than any other entity. So it's common, it's dangerous, and it's expensive to treat. And so if you took a long view, there's no doubt that the imaging catheter would be worthwhile. And I think that's a part of the conversation that needs to be had more often.
Kevin, are you able to share any more of your insights from the Light Lab data with complex PCI, or is that not yet ready for prime time?
Not yet ready for prime time. We're looking at the data cuts now. There's several hundred CTOs in there, and I think 17% of the cases were for in-stent restenosis. And so that's going to be a fun next data cut, which we'll be excited to share, hopefully by our next international meeting. The analysis of that is ongoing now. That's a great segue into the next phase, Jonathan. So we thought we'd share a case. As I talked about the phases of Light Lab, we're in the ongoing part of looking at OCT and MLD max and complex PCI. And Jonathan had alluded to this earlier, and I think, Dwayne and Jonathan and I try to do a lot of education in the complex PCI space, both with fellows and colleagues. And one of the things I'd always been frustrated by was the conversation about what constitutes an atherectomy lesion. Because even within our own hospital, there is a huge variation of practice. And whether or not a plaque needs modification is where the game is either won or lost with regard to stent expansion. And obviously in the case on the right with severe calcium, that's a scenario where some measured approach to vessel preparation is going to help your stent to get expanded. And so with that in mind, because OCT is so high resolution, because it can measure the thickness of calcium, the CRF group has got, I think, one of the most important papers in my mind published in the past couple of years, and we talk about this with each of our fellows every day when we do cases, is just a really scoring system, a good scoring system. It's simple. If you've got an arc of calcium that's between 90 and 180 at 1 point, greater than 182 points, if it's more than 0.5 millimeter thick or more than 5 millimeters long, you get another point. And at 3 points or more, your stent expansion starts to drop off precipitously. So we can start to now have an informed conversation of when atherectomy or advanced vessel prep should be utilized. And so this is nice because it's going to hopefully, to Dwayne's point that he made earlier, help to smooth out some of the heterogeneity. And in scenarios where I see borderline cases, and I may choose a single or maybe not an advanced vessel prep, I always check on the back end and know if I got it right. And that helps inform what I'm going to do the next time. And I've sometimes licked my wounds and wished I've done things differently. But at least from the standpoint of wanting to do a good job, I'm trying to learn what the best strategy is. And now we've got lots of ways to modify vessels, including rota, orbital, and newly on the block in the US is Shockwave. So with that in mind, as we look forward to the next phase of Light Lab, which is going to look at the performance of MLD Max and complex PCI, I thought I'd share with you just a simple CTO case that we did, which was OCT MLD Max guided. It's a patient that has a calcified right coronary artery. The JCTO score here is probably 3. It's more like 2.5, depending upon whether you say that the proximal cap is tapered or blunt. It's sort of an in-betweener. It was retried. It was about 20 millimeters, and it was calcified with no major bends. And so this is a relatively straightforward crossing. We tried to pilot 200, couldn't get across. Because of the short, well-defined area with the contralateral injection, we took a penetrating wire. We're able to get a Gaia third readily into the lumen. And at this point, after a little bit of ballooning, it's not that much different than a non-CTO PCI. We were able to predilate. All of the balloons were constricted in the calcium, not surprisingly. And I'm very comfortable predilating as the first maneuver to get my imaging catheter down. This is what the OCT looked like when we did the pullback. You'll see there's a substantial arc of calcium with 360 degrees. It's more than 5 millimeters long. And throughout most of this segment, it's actually greater than 5 millimeters and greater than 0.5 millimeter thick. The CVI score here clearly is 4 without question. And so this is a vessel which certainly needs advanced vessel preparation. In this particular scenario, I did orbital atherectomy, 12 runs of it, all of them on low, to treat this entire calcified segment, and in particular, the calcified CTO portion. After doing that, our post-orbital NC balloons were still constricted, not surprisingly based on the burden of calcium. So for me, the current cadence is this is a really nice orbit TRIPSY case. We went down and treated the patient. We had to use 2 shockwaves, both based on the length and the sizing of the artery. And there was so much calcium here that we actually had a hard time, despite the orbital, getting the shockwave to deliver. We tried something which is now fondly called shock and go, where we buried it into the lesion, inflated it, did 20 or 30 pulses, let it down, and was eventually able to traverse it a little bit further. This doesn't always work, but it works a vast majority of the time, which is kind of nice. We did a 3-5 IVL treatment proximally. You can see it not expanded and expanded after about 40 pulses. Was able to confirm with 1-to-1 sized NC balloon predilation, something I can't tell well on the angiogram, but I know with certainty based on the OCT. And then this is the final co-registered OCT angiogram after we did post-dilation, and you can see our stent expansion here. The stent expanded quite well. There was a little area of underexpansion toward the distal segment that I touched up with additional high-pressure balloon inflation. I think it just is a nice way to show an example of the use of this technology in a relatively complicated case with a high degree of calcium, but I knew from the calcium burden that orbital alone was potentially not going to be enough. And so I particularly have been applying this a lot of times these days in CTO cases. Once a wire is across and a balloon's there, it's no different than any other case. And I know Jono has a very similar experience, which I'm sure he's going to share in commentary now.
Kevin, can I ask you, and Jonathan, when you use lithotripsy, do you look to see that there's fracturing of the calcium or not, or do you just kind of imply it with balloon inflations? And what about morphology of calcium? Do you alter what you plan to do based on nodularity or circumferential nature of what's your preparation strategy?
So with concentric and eccentric calcium, shockwave is effective. I think you have to tend to deliver more shocks with the eccentric lesions. With nodular calcium, which I think comprises probably less than 10% of the sort of total calcium cases, I would use rotational atherectomy and then shockwave. We don't currently have orbital available in the UK, but I think that's coming soon. I think the practice of looking after you have done the modification with OCT, I think, is a good one. I think we saw within all the Disrupt CAD series of studies that there was a substantial luminal gain after just the shockwave step alone before stent implantation. And it does confirm the mechanism of action. If you can see calcium fractures, then you can see them going from the medial, from the intima through to the media, then you know that you're going to get good expansion. So I think it's a good habit to get into with the initial experience. I tend to do it with all the cases, and certainly, I think it gives you an added level of confidence that the modification step that you've deployed has been effective.